Good evening, everybody. Welcome to the Brain and Spine Group Medical Student Neurosurgery Training Center series on brain metastases. This is going to be the third session in our series, the Journal Club session, where our groups of student presenters discuss some of the contemporary and classical literature in the field. And we've got a great lineup of presenters here. Just to run through some intro materials before we go ahead and introduce our faculty facilitator. So our most proximal event after this one is going to be the second annual Early Career Neuroscience Virtual Research Symposium. It's going to be taking place this Saturday, April 1st at 12 p.m. Eastern. So definitely, even if you didn't submit any materials for that, come and join and support your peers. We have a resident panel lined up to talk about being productive in research during training. We've got a great keynote, one of the chief residents at Mass General Hospital, who's been really driving forward the field of meningioma genomics. Some other things to keep in mind, our next and last session of the Brain Metastases series is going to be April 4th, so next Tuesday, same time, 8 p.m., and that's going to be at Grand Rounds with Dr. Randy D'Amico from Northwell. This Thursday on the neurosurgery journey, we're going to be discussing the IMG experience with a first-year resident from the University of Missouri. And that is going to be it for the intro stuff. Let me take that off. And I'm going to turn it over to Chandler, the co-host, to introduce Dr. Ivan, and then hopefully we can start pushing out with the presentations.
Sure thing. So this is Dr. Michael Ivan. Thank you so much for joining us. He is an associate professor of neurosurgery at the University of Miami, as well as the director of research at the University of Miami Brain Tumor Initiative. He completed medical school at UMDNJ in New Jersey, did his neurosurgery residency at University of California, San Francisco, as well as the fellowship at Jackson Memorial Hospital in Neurosurgical Oncology.
Great. Thanks so much, Chandler. Thanks for the introduction. Really a pleasure to be here today. Looking forward to the session.
Awesome. So it looks like we're still maybe waiting for some students to get on. I don't know if, Jose, do you want to maybe go ahead and get started with your presentation?
Certainly there. Good evening, everyone. This is Jose Chacon. I'm currently a medical student at the American University of Integrated Sciences in Barbados. And we'll share screen right now, my presentation. Okay. Are you able to see my screen there?
Yep, I'm just putting it up there for you. And then whenever you want to put it into the presenter view for yourself.
Perfect. Thank you there. Okay, and for my portion of this presentation is the title of this article called Time to Administration of Stereotactic Radiosurgery to the Cavity After Surgery for Brain Metastases, a Real-World Analysis. This was written by Roth O'Brien et al. At Weill Cornell Medical College in New York. And basically, just give a little background about it. Patients with single or systematic brain metastasis resection can decrease neurological symptoms, improve local control, and prolong overall survival. Radioattack can increase post-operative complications by delaying wound healing and increasing the risk of ulceration and infection, most markedly immediately following resection. The time in adjuvant stereotactic radiosurgery is not well documented, and a subset of patients never actually receive stereotactic SRS for various reasons, such as poor performance status, surgical mobility, rehabilitation, socioeconomic barriers, and treatment of systemic disease, among other etiologies. The purpose of this study was to determine at one point is when, during what point during post-operative is the patients really to have are required for local resection will receive afterwards the time to have adjuvant treatment with stereo radio surgery as part of modality. So in order to do this, so what the author did was they conducted a retrospective study of patients' pathology reports from years of 2011 to 2018 identified adult patients with brain metastasis from solid tumors who underwent resection of intracranial lesions referred for adjuvant stereotactic radiosurgery. Among the inclusion criteria they had was confirmation of the pathology of the intracranial metastatic disease for at least 1 month of post-operative follow-up. Among the exclusion type was receive prior localized therapies such as surgery, prior surgery, as well as also they even had prior SRS and even brachytherapy for brain metastasis. The two endpoints they developed was first off for the primary was, as I mentioned earlier, about the time interval for for SRS. These were divided to a couple of groups. Was less than 4 weeks of surgery. The second group was more between 2 to 4 weeks after surgery. Third group was 8 weeks after surgery, and the fourth group was basically the who have received none, basically the control group here. For the secondary endpoint for it was the local resection brain MRI evidence of new or increasing nodal contrast enhancement within 5 millimeters of the surgical bed. And just on a side note here, in terms of what devices used for SRS were done either by the Varian XI linear accelerator with X naught equipment or on Novice True Beam linear accelerator with X-Track. And here's just a quick show you that each one of these devices here, they eventually do the same thing. The only difference is that one does a positional while other does a more of a fixed position there. So just to give you an idea, differences. Of course, they're very similar, and the only differences are brand, mic, etc. there. So at the end result there, 159 patients met the inclusion criteria. The mean follow-up was about 10.7 months, with about 150 patients, or 72.3% of the patients done follow-up for more than 6 months, and 74, or which is about 46.5% of them, for greater for 12 months. Only race, cancer origin, and years of treatment and systematic treatment after operations were the only data where had statistical significance. In the next couple of slides, I'll show you the graphs in which that will demonstrate this. There was no significant differences in the local resection of focal stare was observed between patients who initiate SRS at less than 4 weeks of resection and patients whose SRS was completed at greater than 4 to 8 weeks post resection. A median survival was not reached in these two groups. Patients with SRS were completed at greater than 4 to 8 weeks had significantly prolonged LRFS compared to patients whose SRS was delivered at greater than 8 weeks, with a mean survival of 16.7 months for the latter. There was no significant difference in the patients who received the SRS at greater than 8 weeks and those who would not complete SRS, with a median survival of 18.1 months in the latter group. There was no differences in local resection or local section focal surgery between patients receiving SRS at greater than 8 weeks and those who had not received it. Among those, the issues for what caused the delays for having status greater than 4 weeks were among those were logistics, disease comorbidity management, and compliance. So as you can look at this graph here, it shows that as the percentage for there was for figure 1, as time goes, as increasing for surgery, for post-surgery in weeks, we see that the amount of local resection increases there. For figure 3, we can see here that with years over time, the longer the stay for surgery, the amount of time for have diminished times, especially for days. And then here, I want you to focus on attention on table 2, where it basically shows you some of the, as I mentioned earlier, about some of the reasons for it. And as you can see here, among the examples of some of the logistics that were involved, like appointments with radiation, basically appointments with the oncology, neurosurgery, as well as also time for MRI, other imaging, planning, delivery, and so forth. The other second was the management of the comorbidities and managements I was mentioned earlier. Among those modules was basically systemic therapy initiation, primary disease workup or management, as well as also basically progression and any other metastases, especially to the spine there. and of course, thirdly was the comorbidities there. So basically, that if you look at figure 2 here, when you determine the stratification by weeks after resection, you'll see that as time for local resection increases, the amount of time for the focal surgery diminishes, especially those basically saying that the sooner they get the surgery there, the less time they require for local resection of the cancer. And then if you see here, once again, there's just repeating what I was just saying earlier concerning about some of the reasons for the failure to initiate or delaying for the SRS within 4 weeks for all patients there. One thing I want to bring up was the fact that despite this research here, some of the author has reported that there were some limitations with this study, and among those limitations was the fact that the study was conducted in a retrospective manner, which the issue will be is due to biases and confounding factors that could cause it. And another reason for it is that they, as well as also since this was taken years before the published study came out in 2021, and what happened is that over time, treatment modalities and treatments for cancer has improved over time, but because they were but since those modalities were not existent, since this was done retrospectively, so rather what was done or not, what kind of modality was used, may be considered discontinued or obsolete to current standards. But nonetheless, this study demonstrates that a time resection for injury SRS was the most significant predictor of local resection. The histology and earlier treatment times for the brain MRI to SRS correlate with time to SRS was very significant, as was also logistics, management, and primary systematic disease comorbidities were the most frequently encountered reasons for prolonged intervals to adjuvant SRS. Obstacles that are anticipated preoperative SRS, and they mention here in the article that intraoperative Chacon-Bradley can be considered if there's any greater discrepancies or delaying further, particularly after 8 weeks. So they may have suggested that maybe intraoperative brachytherapy can be considered if SRS cannot be done sooner. Thank you for your attention there, and wait for your any questions there. Thank you.
I don't think I see anything in the chat. Thank you so much for your presentation. That was really thorough. You had some really great graphics to help. I think Mike is making sure that no one on YouTube or Twitter is sending anything.
Yeah, not seeing anything on right now.
So, I mean, I'll make a couple comments. I mean, it's an interesting study. I mean, I think there's a couple things that when I look at these trials and these publications, you know, the first thing I always think about is I try not to jump to the conclusions, right? I try to kind of just understand the format of the trial and how the data was perceived. And in this case, you know, the big question for me is why they lumped the last group into greater than 8 weeks, because that's a pretty large. It's like 8 weeks to 2 years or 3 years. It seems like that's a weird cutoff to have, because I think 8 weeks is probably going to be different than somebody who gets radiation, 35 weeks afterwards. It's a pretty big gap. So I think that group is a little bit skewed worse than it is. And then, it is interesting that they then went ahead and tried to understand what is the delay. And I think the real thing that they missed there was kind of the socioeconomic status, right? Which is, I think, what they're really alluding to by they talk about logistics, or they talk about, I forget what else was in that graph, but, they talk about a couple different other things of reasons for that. But I think that there's a huge, thing with language barriers and socioeconomic status and insurance status. And when you talk about cancer patients specifically, and the timing of their treatment, whether it be chemo or radiation, those tend to be one of the most impactful kind of reasons why patients are getting delayed. I mean, obviously you have the patients who have post-op deficits and are in rehab, right, and can't get radiation, or you have patients that they find out the disease is, is too diffuse and they can't get it. But when you look at on the majority of people who have already gotten to the point of getting surgery, they're already tapped into the system. Why do they then fall off the chart and not get the radiation? I think it's that status and their insurance abilities that's really limits them. You can picture a lot of these patients that have brain tumor surgery, they come in with with an emergent symptom, right? You don't just kind of find out that you have a brain tumor and then a couple months later you schedule your surgery. It's normally you have a seizure. Oh my God, I have a tumor and now I need surgery right away. And so that happens without it. Then they leave the hospital and either they're not in the insurance network. They have to wait to find somebody. They don't have insurance at all. They don't have family that could take them back and forth to the radiation because they just don't have the support. They can't leave their job. These are all critical factors. And then the final comment that I want to have is just, what does the future look like? And, one of the things at the end, the conclusions is preoperative radiation. And, we have, that's really kind of where we see this kind of moving towards, is you identify the tumor and then you try to radiate initially and then surgery during this almost the same admission, eliminating this whole problem to get-go. And the other thought process is that it's much easier to identify the tumor margin preoperatively. And so that was the other thing they didn't talk about is that the tumor margin, you can imagine you have the brain, you take out this very obvious tumor, and then after surgery, you have a little bit of bleeding, some swelling, the cavity kind of shrinks and then it gets bigger. And so the radiation, when they plan, they plan based on the what they think is tumor and what we think is the resection cavity. Sometimes it matches the preoperative image really well, and sometimes it doesn't. And then you kind of have to estimate and draw that curved line of where you think that margin would be of, the resection cavity plus 2 millimeters. And so at different time points, 4 weeks, 8 weeks, and such, the cavity kind of changes its shape and changes of conformity. And that's one of the other major issues that we're seeing is that why there's so much variability with some of the local control rates postoperatively, whereas preoperatively, you know exactly where the tumor is because it's bright on the MRI with contrast, and then you could do this 2 millimeter margin around it to include in the radiation, and it's very consistent in that you're going to get the tumor plus the margin. So a couple clinical trials that are coming out to show that that's kind of the way to go, and I think that's what you're going to see in the future.
Thanks, Dr. Ivan. We do have a question from Aaron, I think, down below. I think they're saying good job in the presentation, and then they're asking how long the treatment takes and what's the impact in the future of neurosurgery.
How long does I guess they're talking about how long does the radiation treatment take?
Yeah.
I mean, again, that's a whole other question. I think we're going to get that later on to one of the papers. It depends on the size of the resection cavity. Most of these tumors, though, are treated in one fraction, like an SRS, stereotactic radiosurgery. So the treatment course just takes a few hours. So it's not too labor intense. If it's larger, then you could do hypofractionated, or for some kind of fractionated radiation. The impact on the future of neurosurgery is, I mean, so far our jobs are still intact. I don't think that that radiation is going to take us out of the game because we're always going to need tissue until we get better ways to molecularly diagnose the genetics of these tumors with blood samples.
Yeah, I think that's really interesting. Do you mind highlighting a little bit just how developments in SRS and even molecular profiling and targeted treatments have kind of changed since you've been in practice, and how you incorporate all of those into your practice?
Yeah, I mean, that's a pretty broad question, but I mean, I think we've seen the pendulum kind of swing, in different ways. I mean, we started off with this idea that these tumors are metastatic, and so you're worried about disease throughout the brain and how we need to do whole brain radiation, to the idea of well actually that could probably injure a lot of the connections in the brain and have long-term consequences. And as we get better and better with chemotherapy and other treatments for these diseases, these patients end up living longer and longer. And so quality of life and neurocognitive status becomes more important when you're living years rather than just months. And so now we're kind of switching back towards these more stereotactic radiation things and kind of just dealing with recurrences as they occur, because it protects more of the brain. So I think that's one of the biggest changes that we've seen over the last like 20 years. I think going forward is just really, how do you combine a lot of these different treatments together? How do you combine immunotherapy with radiation, or where does sonotherapy kind of fall into this? How do you do laser surgery and combine it with these other ones to try to come up with the best combinations for optimizing control rates?
Awesome. Thanks for that. So I'm now going to put Eden and Derek on the screen here. So guys, how about you go and introduce yourselves and then kick off with your presentation. I'm going to just turn my camera off so we don't crowd out the screen here.
Yeah, sounds great. Hi, my name is Immaculate Christie, and I'm currently at M1 at Georgetown University School of Medicine in DC. And Derek, do you want to introduce yourself?
Oh, all right. I am Derek Yeta. I'm from Addis Ababa, Ethiopia. Currently, I'm a third-year medical student at Myeongsang Medical College here in Addis Ababa.
Great. I will share my screen. Sorry.
Yeah, it's going to be that center button right next to the video.
Right. Hold on. Can I share like my, does it have to be on my Google Chrome, or can I share like my PowerPoint, like Microsoft PowerPoint?
Yeah, so there should be an option for Chrome tab, and then in the middle, do you see window?
Yeah.
So if you do that, then the PowerPoint should open up.
Can you guys see this? Or the PowerPoint, or no?
Okay, so now I'm just seeing the infinity window here.
Okay, so then let me, okay. Let me just open up the slides on Google. Can we see this now?
Yep, looks good.
Okay, so yeah, the title of the article that we're presenting today is The Role of Surgical Resection in the Management of Newly Diagnosed Brain Metastases by Stephen N. Kalkanis et al. So this article is essentially a meta-analysis that ultimately aims to come up with clinical recommendations for optimal therapy combinations for adults with newly diagnosed single brain metastases. A little bit of background, 1.4 million Americans are diagnosed with cancer every year, and about 500,000 per year of those patients go on to develop brain metastases. And approximately a third of those will be potential candidates for surgical resection. Some factors favorable for surgical resection is if it's a single metastases in an accessible site. And also when we're talking about brain metastasis, we're usually at the end of the cancer's course. And at this point in the patient's treatment, we're looking to maintain neurologic function and quality of life and prevent any brain lesion-related mortality. I've listed some possible therapies for brain metastases or primary tumors. So that includes surgical resection, whole brain radiation therapy, where the median survival range is about like 3 to 6 months if it's used as monotherapy, partial brain radiotherapy, and stereotactic radiosurgery. And this is pretty ideal if you have like around less than 5 brain metastasis and the tumor volume is under 3 cubic centimeters. The next few slides might seem redundant, but I kind of just wanted to add it in because going to this paper, I didn't know the difference between WBRT and SRS, but WBRT essentially is basically what it sounds like. The patient here is subject to radiation all over their brain, which stops like microtumors that might not be readily visible in imaging. that it also irradiates healthy areas of the brain, leading to more symptoms such as memory loss, fatigue, and hair loss. SRS is essentially a more concentrated radiation beams aimed at the tumor directly at the tumor from many different directions, and it spares more healthy brain tissue than WBRT or RT. So the objectives of this paper, as I had stated earlier, was to systematically review current evidence to compare combinations of treatment modalities, and they came up with 3 categories of comparisons they wanted to data pool. So the first category was surgery versus WBRT plus or minus surgery. The second category was surgery plus or minus WBRT or RT versus SRS plus or minus WBRT or RT. And the third category was surgery plus or minus WBRT versus surgery plus SRS. And this is all to eventually give recommendations to adults with newly diagnosed single brain metastasis indicative for surgical resection. For the methods, they employed a broad search strategy from various databases that I have listed down there. And they looked for articles from 1990 to September 2008. And the eligibility criteria that they chose as papers with is that they should be published in English. And the study should include patients with newly diagnosed brain metastasis. They have to be fully published in contrast to just abstracts. And the study should include comparisons, which I have also listed down there. And there should be greater than or equal to 5 patients per study arm for at least 2 of the arms. Oh, and I should say that each article should have 1 or more of those comparisons that I've listed in the box. For studies exclusively studying patients with newly diagnosed metastases, baseline info was obtained from the treatment group. Whereas studies that include mixed populations, which are patients that have other diseases like chronic diseases as well, the baseline information was obtained from the treatment subgroup of patients with newly diagnosed metastases. The study selection and quality assessment was essentially carried out by 3 independent reviewers. The 2 independent reviewers evaluated citations using a priori criteria, and then the 3rd independent reviewer resolved cases of disagreement. When they accepted an article, the data was extracted by the 1st reviewer and checked by a 2nd reviewer. And then the quality of various factors was essentially assessed by certain scales. So for example, the Pedro scale was used to assess the quality of randomized trials, and other existing scales, which they didn't name, was used to assess the comparative studies using non-randomized designs. And then they used the AANS and CNS criteria to assess the quality of evidence and strength of recommendations. And the right here is essentially a flow chart kind of indicating how many articles were left out based on the eligibility criteria or exclusion-inclusion criteria. And then we came down to 15 eligible studies.
Okay. Okay, I was just
just tell me when to
present and use. Okay. So as my partner stated, there were several different methods of treating these METs, and they've analyzed basically the different combinations and permutations that would yield the best results. So the first comparison that we see is the surgical resection versus surgical resection in conjunction with whole brain radiation. So there was one randomized control trial in the US, Pacho et al. I think it was published in 1998. Basically compared the outcomes of patients who underwent surgery and then were followed up with whole brain radiation. And also there were 3 other retrospective cohort studies. So the Pacho trial looked at patients with Karnofsky scores of greater than or equal to 70. So generally, these are patients who can take care of themselves, who are independent, and also looked at the patients with a complete resection of single biopsy confirmed METs. There were a total of 95 patients in this study. So out of the 95, 49 of the patients received whole brain radiation therapy post-surgically, and then 46 of them were just observed after their surgery. So the study was conducted with the intention to treat, and the primary outcome in this study was to check if there were recurrences in the brain, either locally or just generally any other distant METs. Next slide. Okay, so we can see the numbers. So generally, the median survival didn't really increase that much in the whole brain group. You can see the 43 weeks to 48 weeks. So generally, they only had about 5 weeks on the surgery group. But we do see some differences in the recurrence and the progression. At the original site, the whole brain group tend to do a bit better. We only had 10% recurrences compared to the 46 in the surgery group. Even the overall, actually, the whole brain group tend to do better than the surgery only group at 18% compared to the 70. It's not just the rates of recurrence, but also the time it took for the recurrent METs to appear. It took only 27 weeks for the group with only surgery compared to the greater than 50 weeks. So that's basically double the time. In the overall METs, we compared the first group 26 weeks and the second group at 220 weeks. So almost 10 times as much. Next slide. Okay. And the other comparison is between surgical resection either with or without whole brain or partial brain, but just some form of radiation therapy to the brain, versus stereotactic radiosurgery with or without some form of radiation. So there was one randomized control trial and 9 retrospective cohort studies that met the criteria for this comparison. All but one used a single dose of SRS. The others fractionated the doses. Next slide. Okay, so the first permutation in this category is surgical resection plus whole brain radiation versus stereotactic radiosurgery alone. So there was a study from Germany, the randomized control trial from Germany. I think it was Immaculate from 2008. It was initially planned to include 242 adults, but due to poor patient accrual, it did not manage to get that much patients. So it only had 64 patients. They all had small METs measuring less than 3 centimeters. They were operable METs, and baseline prognostic variables were similar in both groups. Their KPS score was greater than or equal to 70. There was no patient that was lost to follow-up. Next slide. Okay, so survival didn't really show a significant difference. We can see the SRS group at 10.3 months compared to the surgery and whole brain group at 9.5. Distant recurrent control was more effective in the surgery and whole brain group, but there was really no significant difference in neurological deaths in both of these groups. We can see 97 compared to the 82 at 1 year local control rates, and also 26 compared to 3%, which is pretty significant. Next slide. Another permutation is surgical resection and whole brain compared to SRS and whole brain. So there is actually no prospective study in this category. There were only 4 retrospective studies that met the criteria. And 2 of the studies, actually, not all of them received whole brain therapy. Only a majority of them did. And in 3 studies, overall survival didn't change all that much. And 1 study showed a significantly longer survival for the surgery and whole brain group compared to the stereotactic radiosurgery and whole brain group. The author sort of describes that this could be due to the fact that SRS candidates are generally poor candidates for surgical resection, so that might take away some points from their prognosis. Next slide. Okay, so we can see the first one over there. So there's the surgery group had about 16.4 months compared to the second group, the SRS group, at 7.5 months median survival. So that's actually slightly more than double. That's slightly more than double the survival. But the rest we can actually see, especially in terms of recurrence rates, they're more or less similar. So as you can see, the struggle data, you can see that group 1 it's at 17% compared to the group 2 at 5%. So more or less similar rates when we compare the surgery group versus the radiosurgery group. But one interesting finding is in the O'Neill data, where it suggested that the SRS group actually had 0% recurrence for local occurrences, compared to the 29% in the the SRS group had 0% recurrence, compared to the 17% in the surgery group. Next slide. Okay. So in summary, when we compared surgery plus whole brain versus whole brain alone, there was actually class 1 evidence that combining these two with patients, especially in patients with good performance and limited extracranial diseases, was actually more beneficial. But there's actually no sufficient data to suggest that patients with poor performance or advanced extracranial diseases or multiple METs would benefit from combination of surgery and whole brain. Next slide. And also looking at surgery and whole brain versus surgery alone, there's actually class 1 evidence, the PATROL trials, to support a level 1 recommendation for single METs. Class 1 evidence supports using whole brain as an adjunct therapy post-op for these patients. Sorry, actually, the study did show, my bad, I forgot to edit that part. The study did show a reduction in neurological death, but there was actually no significant difference in overall survival rates. There's also no difference in time of independence. So this is generally the time in which these patients spend, the time in which these patients have a KPS score of greater than or equal to 70. So there was no significant difference in that time period. Next slide, please. Next slide.
This is the next.
Yeah, that one. Yeah. Okay. So there's actually class 1 evidence that answers this question, whether or not to do surgical resection and whole brain versus stereotactic surgery alone. So the Immaculate trials, although this trial is actually underpowered to make any guidelines from it. One of the reasons being that it did not have the appropriate number of patients. It only proceeded with about 1/4 of the patient that it intended to enroll. The authors from the study actually calculated 38% or greater differences between the groups 80% of the time. So it's actually quite difficult to propose any guidelines from the study. Next slide. And also the duration of freedom didn't really show a significant difference, the 97 versus the 82, at least in the first year. So a larger trial could provide information on this. There was actually a trial by the European Organization for Research and Treatment of Cancer that was actually set out to do this exact same kind of trial. Since this paper was published in 2010, it actually didn't get the results from this study. The study came out a year after that. I actually didn't get a chance to read it, but this actually sort of answers what the previous study failed to answer. Next slide. So then comparing a surgical resection plus whole brain versus surgical stereotactic surgery and whole brain. So there's actually class 2 evidence comparing the two that yielded conflicting results. So there's class 2 evidence that prefers surgery for larger tumors, especially the ones that cause significant midline shifts. These are basically tumors greater than 3 centimeters causing a shift of greater than 1 centimeter. Radiosurgery would be recommended for lesions that are less than 3 centimeters, so the small ones. tend to do better with radiosurgery compared to traditional surgery. Next slide. So in conclusion, surgical resection and whole brain was actually a superior treatment modality compared to either surgery alone or whole brain alone. Larger lesions actually had better outcomes with surgical intervention compared to stereotactic surgery. And also SRS provided a better treatment for radio-resistant lesions because it concentrates the radiation in that particular area, in that particular tumor. And there's actually a level 3 recommendation for SRS alone, but provided that the patient would undergo monitoring and undergo salvage therapy if there are recurrent mets. So possible future directions, as stated by the author, there's actually no data that would compare SRS post-op, as in surgery, traditional surgery followed by SRS. So that data is basically non-existent, at least at the time of this publication. And also surgery for multiple mets. We also don't have enough data to suggest that would be beneficial, at least at the time. And also the trials that focus on the quality of life. Most of the trials that we've actually stated, they either tend to focus on median time of survival or recurrences, either distant or local. So none of them actually consider the quality of patient's life. And also histology-specific trials. We also don't have any trials that focus on the type of cancer tissue while we are looking at this study. So these are the things that the author said that would be possible directions in the future that we would actually study with regards to brain mets. With that, I finish my presentation. Thank you.
And that is all. Thank you.
Thanks, guys. That was great. That was a difficult article for you guys to analyze, but you both did a really good job. And that was really comprehensive. So thank you.
Yeah.
Are
I
there-
did have a question for
Yeah.
Dr. Ivan. For the previous paper, you talked about preoperative radiation and then doing surgery after that. Were you saying that's already, is that already being done, or there's some potential benefit to it? I guess my question those are my questions, but also wouldn't preoperative radiation kind of mess with the brain matter or make it, more fragile for operation?
Yeah, great questions. Yeah, so there hasn't been a full class 1A, class 1 clinical trial that's done this, blinded, but there is some pretty convincing evidence thus far to suggest that this is beneficial in patients that can. Now, there's, again, medicine's an art, and as you're seeing, as you get more into that as papers, there's not the right answer for every patient, right? It's just like as the end said, what happens if you have 2 large mets? Is that now you're not eligible for surgery because it's only for 1 met? Well, no, that's not true. I mean, if you have 2 large mets and they're both symptomatic, then in certain cases, they both deserve to be removed, but that's not the standard, right? So every patient's a little bit different. So if you have a patient that has a lot of edema, a lot of swelling, possibly doing radiation first, you really don't have time to organize that and to get that going and mobilize that. So surgery in those cases would be more important. But if you have a cancer patient that you're monitoring the brain and you happen to see a met and it's growing, then you have the time to possibly treat that first and then remove it. Then that would be a better option. Radiation doesn't really affect the brain tissue, especially in the short term, because radiation takes many days, weeks, sometimes months to even kind of do its thing. And so to have those changes of gliosis or changes in the vascularity or changes in the fibrosis of the scar tissue take time. And so the biggest risk is just really the wound healing, which is the only issue that you have to kind of consider in some of these patients.
Okay, thank you.
We don't have any other questions here, Mike. Is there anything on your end?
I am not seeing anything here. And it's looking like we got ghosted by our other group of presenters, which is actually very disappointing because they sent slides and seemed like they were prepared for it. Also disappointing because it's Dr. Ivan's paper and we wanted to show it off for him. But Dr. Ivan, I don't know if, obviously we don't expect you to recite every p-value, but do you want to just give us a little bit of an overview of how you've integrated MRI-guided LIT into your treatment approach?
Yeah, I mean, I think the subtle finding in the last paper especially is that if you look at the overall survival of these patients, the overall survival tends to be less than the local control. And so what that's telling us is that we're actually doing a better and better job at controlling the brain disease and not as good with the overall survival of these cancer patients. And one of the reasons that that's happening is because we are developing new technologies such as LIT, where we could continue to kind of treat locally and kind of, put out these small fires that are happening in the brain, especially when they're focal kind of lesions and not leptomeningeal, which is kind of the whole meninges. So how do we do that? Well, I mean, radiation is obviously, we've seen a ton of data tonight saying that radiation is very effective, and especially targeted radiation. But it's not everybody. There's a lot of patients, unfortunately, that have brain cancer from METs. It's the most common thing. And, even not being able, even having a local control rate between 80 and 90, that still leaves a lot of people that are recurring. And so what do you do when they do recur in that spot, which wasn't really talked about yet? And, reirradiation to the same area definitely has its risks. And the other thing that wasn't brought up was this idea of radiation effects or radiation necrosis that happens after the first round of radiation. And sometimes it happens in a way where it's even hard to tell, is that progression of recurrence and progression of the disease, or is it just inflammatory responses to the tumor? So that's kind of where laser comes in, because it gives you another treatment option to go in there and locally treat the tumor. You're already in there, so you can get a biopsy. So now you could get more information about how much of the tumor has radiation effects, how much of it's actually live tumor. And you have another opportunity to get the kind of the genetic status of the tumor because you do a biopsy. And while you're in there, you ablate the tumor, which is done with thermal energy, with a laser energy that basically kind of turns into thermal energy and just kind of cooks the tumor and its surrounding. This really is something that's fairly recently been used in practice, because now for the first time in the last 10, 15 years, we could actually use something called MR thermometry, which allows us to actually see in real time the brain heating up. So as before, it doesn't take a lot of science to put something in the brain and heat it up, but obviously it's critical to know exactly what the temperature is and how much you're heating and where are the boundaries and how it's working. And so with MR thermometry, we actually could do that. So the patient's actually in the MRI scanner getting scans every few seconds, and you can actually see the temperature around the probe start to warm up, and you could set temperature alarms so that the system shuts down if you reach a certain temperature. And then you could actually kind of even move the catheter to kind of change the shape of your ablation in real time. So so those are kind of the benefits. I think it's nice because in a lot of these patients that recur, the option is you have to go in there and do surgery, but they've already had radiation, they're already on chemotherapy, their skin is quite fragile, or their whole disease state is quite fragile, and they don't really they have a little bit of higher risk than the normal patient of undergoing a large invasive surgery. So with laser, it's a 1 or 2 millimeter puncture into the skin that we can place the laser into the tumor and then do a very similar treatment as a resection, it turns out. So this paper that we were going to talk about tonight was just talking about how many times can you do a laser to a lesion, and that's kind of something that was a novel finding that we published on, and that because it's unlike radiation, where the more radiation you give somebody, the more chance you could cause this massive inflammatory response. With laser, you're just basically heating and killing the cells. And so the question was, well, can you just keep doing that over and over again? And it turns out you can. But obviously, the control rates kind of go down as you have to do it more and more, just because those tumors tend to be a little bit more diffuse. And so even though you could see certain things on the scan, you're not getting the entire disease in that spot because there's cells that are outside of the MRI capability of visualization.
Thanks, Dr. Ivan.
Yeah,
that was very helpful. And not good that they didn't show up, but convenient that if it was going to be any paper, at least we have you to speak to
it. Sure, no problem.
We're just getting about to the hour. Any other questions? I'm not seeing anything on my end in the chat.
Yeah.
I mean, just something general, Dr. Ivan, we always like to ask when we have faculty on, what drew you to neurosurgery and then specifically into neurosurgical oncology?
Yeah, I mean, great question. I think for me, it's just, it's the frontier of unknown with the brain, and just knowing that there was going to be so much discovery in my lifetime, and to be a part of that and learning every day something new about, this organ is just incredible. And so, if I could take a small part in that, I think that's really, really cool. Just understanding how it works, how to make it better, how to repair it, how it does all these things on its own. It's just so much that we really don't understand. It's kind of crazy. We spend weeks and weeks in medical school learning about it, but when you finally start asking the hard questions, people are just like, I don't know. So I think that's exciting. Surgical neuro-oncology for me is exciting because every case is different. Especially, I do skull-based tumors and intrinsic brain tumors, and every case is different. There's no two tumors that are the same. So you never feel that repetitiveness of when you go to work that this is the same thing that I've done 1,000 times or whatnot, right? It's just every patient is different. They all come with their different, environment that's around them, their different medical status, but more importantly, just the actual structural differences and their connections of their brain around their tumor are different. And so every kind of case is like its own little chess match. You have to kind of figure out what is the best strategy to protect that patient and to remove that tumor, and what are your limitations and what are not your limitations. And in every case that you do, it's a little bit different. And so you're always kind of learning.
Well, you sold me. That's pretty cool.
Yeah, it's good. I mean, there's so many great things about neurosurgery. It's for me, being hands-on every day, accomplishing something, that when you go home every night, you've helped somebody and you've made a difference in their life. And it's some patients do really well and some people don't. And for me, as brain tumors, we treat all ages, all types of tumors. A large amount of people we cure, and there's a large part that we don't, and that kind of balance keeps it really interesting. And it's just exciting to be a part of somebody's life, in such a critical moment, and to help them in any way. So, yeah, I could go on and on about this topic. I'm super passionate about neurosurgery, but
we'll definitely have to get you on the neurosurgery journey at some point, and we can have a full discussion about all this type of stuff. That'd be great.
Sure.
Right, thanks so much. Hopefully for some of the earlier M1s and M2s out there, what you just said kind of lures them in even more, and they can keep coming back to participating in things like this. So thanks so much for coming. Thank you everyone for your presentations. They were great. Thanks for spending your night with us. And thank you so much to Dr. Ivan for taking time out of his very, very busy schedule to offer some more knowledge to everyone.
Take care. Thank you so much.